part, patients still end up needing kidney transplant. But hold on a second. I can tell you that for every year you take your cysteine depleting therapy, you add a year of kidney survival. So if I took a whole bunch of nephrologists and got up there and said, hey, by the way, I have this new treatment for this other disease, disease X, and here's a treatment that gives you an extra year for every year, that would be the best thing ever. So that shows you how effective this therapy can be if you take it, basically. Oh, wait. Next slide. And then this is this idea that, it's kind of scary when you say, well, you could have altered neurocognitive development. What does that mean? But once again, we have evidence that the treatment works. It doesn't just work in the kidney and the eye, but we have evidence that it works in the brain, that you take your treatment and you do better on these neurocognitive tests. So that's exciting. Some data. So, and then this idea is this poor adherence can lead to inadequate therapy. And this is this idea that, unfortunately, we have a treatment, but the treatment, the tolerability of the treatment is poor. There's no question about that. And one of the things that limits our ability to give cysteamine is this idea that it's not tolerated well. There's not a patient out there that I haven't found that has GI upset or tummy, that their stomach does not react well to the treatment. And one of the challenges, 2 minutes, I got to move through. So this underlying GI is that, but this idea, the tolerability, that leads to poor adherence with the disease, poor adherence with the treatment. I'll let you know that that this idea that you always have to tap that metal guy in the shoulder. We have evidence that if you go past the 6 hours, that cysteine starts to accumulate, and the lysosome is up for destruction. That trash fire is imminent if you're not tapping that guy on the shoulder. Most of you guys understand that there's 2 forms of the medicine. There's the regular, the immediate release, and then there's also a delayed release. They're exactly the same medicine. One's given every 6 hours, one's given every 12 hours. A lot of patients have different preferences about which one they like to take, and that's one isn't necessarily better than the other, and it's really a choice for the patients. But I think most of us are familiar with this idea of a delayed release concept. You see it on the nightly news. I take this pill and it's released over time. Minnie already went over this idea that this renal transplant, for whatever reason, we don't fully understand this. Patients who get a renal transplant and have cystinosis seem to do better. And so that's a little bit of a bright area that if you're going to get a kidney transplant. And Dr. Grimm's going to go over some of the good and the bad, and I'll talk briefly about the ugly of kidney transplant. But a lot of times the good news is we can plan for a kidney transplant. There's better survival, there's less cumulative immunosuppression, and there's less rejection. See, I think the bad news here is this idea that you still need to stay on therapy, obviously, because we fixed the kidney. We've given that kidney comes with its own lysosomes and recycling plants, and they do well. However, this idea that when you get the kidney is in a very difficult age group, the teenage age group. And I've started to realize now, having a teenager at home, that teenage years, and I was a teenager, believe it or not, is a disease in itself, where you start yelling at your parents, you get real grumpy, or more grumpy, I'll say. And I just throw up this slide to remind you that, this is data that we take from the transplant, and the idea that when we look at survival of a kidney transplant, all comers, teenagers have the best 1-year survival. And that makes sense. They're adult size, they're ready to get a kidney, they have less of diabetes and heart problems, but their 5-year survival with the kidney is the worst. And we don't have all the answers to why that is, but we no doubt a large component of that is compliance with medications. Is that there's something about the teenage brain that says, well, I don't have to worry about tomorrow, I'm worrying about the now, I don't need to take my medicine. So we think that has a lot to do. And if you think about when patients with cystinosis get a kidney transplant, that's right in that age group, right? And then add into that fact this idea that something we've all become very interested in, and me particularly, is this idea of when do we transition our patients? Like where I work, they said, well, Dr. Zaritsky, at 18 or literally at 21, you can't see that patient anymore. Why? That's set up due to rules of the government, what is a pediatric patient, whatever it is. But this idea that you've been living with this disease, now you have a chronic disease that you're taking all these pills, you got a transplant, and now all of a sudden I say, see you later. What do you mean see you later? You've been taking care of me for 21 years, and now I got to move to an adult doctor who might not know as much about the disease. And so I include this quote up here, this idea of that the teenage years is sort of this perfect storm of regular problems, and then we add in this idea of adolescent, are you taking your meds, are you not taking your meds? It's a it's a difficult time anyway, and then when you add chronic disease into it, it's very difficult. So one of the things I've been trying to work on in my own kind of plug is to say, hey, can we find doctors, and I'm very interested in these med-peds doctors, patients, they're sort of like family practice doctors who have been trained in internal medicine and pediatrics. Maybe those are the group of doctors that we should have at this conference who end up being the PCP of the cystinosis patients, and they can follow the patient throughout their lives. So one of the doctors I'm partnering with is an endocrinologist who's a med-peds endocrinologist. So I don't have to worry about my patients, at age 21 having to go see another doctor. And they can get through this very, very difficult portion of their lives, the teenage lives, without having to worry about who's going to be my doctor. Who's going to be my doctor? So, and then this is just to remind you that I'm up here, but I rely heavily on a treatment team. And for example, for treating chronic kidney disease, I tell my nutritionist, I literally tell her, I work for you. You tell me what the patient needs to get, and I'll support the patient with other medicines or dialysis as much as possible. So this idea that you really need a whole team taking care of the patient with these multi-organ diseases, and that you think about that it's not that you're just transitioning from your nephrologist to another doctor, but you have to transition 5 or 6 doctors, and then add in your nutritionist, your social worker, your psychological support. That the transition period is extremely, extremely difficult. But it can be done. It can be done. So in summary, I went a little bit over. Cystinosis is a rare, but look at this. I need to up the font here, is but treatable disease, right, that affects every cell in the body. This idea, if you don't think of the diagnosis, you'll never make it, or now I need to change it to say, you might not have ever seen the disease, but the disease has seen you. And then sort of the current treatments that are available. But I want to always remind you that whenever someone gets up there and says, what are the current treatments available, they're looking at data that's years old. So we know that the treatment's effective. We don't know what that treatment arena is going to look. And thanks to groups like the CRN, treatment, I can guarantee you treatment of cystinosis is going to be different in 5 to 10 years. You're going to keep me as a clinician on my toes, which is great. And then I'll just throw one other thing out there. At our big meeting, our American Society of Pediatric Nephrology, we had a meeting where we had a cystinosis kind of working group, and I was just talking with another colleague about an extremely rare disease that we see that affects the proximal tubule, and the colleague turned to me and says, we're never going to have a treatment for this disease. There's not enough patients, there's not enough awareness. And then I heard this treatment of cystinosis, with this bone marrow transplant where their macrophage can then go out and actually donate a lysozyme to. And then I realized sitting there, I'm thinking, oh my God, this treatment could be put over to another extremely rare disease. So this idea that, by treating a very rare disease, you open up this idea of other treatments for other diseases. Even that idea of looking at somehow being able to, remove a protein from the lysozyme, right, that helps to prevent the kidneys from deteriorating, that could be applied to every single renal disease out there. So I want to acknowledge the people in this room and how powerful your advocacy has been, and how it's going to help it's going to help patients with diseases you'll never ever hear about. So I wanted to say thank you, and thank you for having me.
Thank you, Dr. Zaritsky, for that great summary of cystinosis. I think your recycle analogy should probably become standard practice. Paul's recycling analogy should become standard practice for explaining cystinosis. It's fantastic. So our next speaker will be Dr. Paul Grimm. He's going to talk to us about anticipating renal replacement therapy. Dr. Grimm?
Thank you. So, can you hear me now? Okay, great. So, there we go. Thank you very much for inviting me here, and I really appreciate the opportunity to speak to you. This is an educational session that I often speak to in pieces to patients sitting in front of me. And this could be about other diseases other than cystinosis. So, and it's relevant to people who have their own kidneys, who are losing them over time because of cystinosis. But for all you people who've been transplanted, it's also relevant for you too. The average kidney transplant from a deceased donor functions 10 to 15 years. The average kidney transplant from a living donor, 15 to 20 years. So most people who get a kidney transplant as a child or young adult will need at least one other kidney during their lifetime. So understanding your kidney function and trying to predict what's going to happen in 2 years, 5 years, 10 years is going to be really relevant. Now, and these are patients who have cystinosis whose proximal tubule was microdissected by a really, really skillful researcher. And when you have cystinosis, this is a 14-month-old. This is the glomerulus, this is the distal tubule, and the proximal tubule is basically gone by 14 months. There's a lot of damage. When you consider most people with cystinosis are diagnosed at around 12 months, 14 months, 16 months, there's a lot of pre-existing damage. When cysteine depleting therapy was developed, we hoped that cysteamine therapy would prevent kidney failure. But the reality is by the time patients are diagnosed, the horse is out of the barn. You can delay the kidney failure, but it's very, very rare that someone actually doesn't need dialysis and transplant sometime in their life. So, when you're talking to your doctor about your kidney function, we talk about the stages of chronic kidney disease, or CKD. And stage 1 is when you know you have a kidney problem, but your GFR, the glomerular filtration rate, is normal. So you can look at these numbers as like 100% or is normal. So anybody diagnosed with cystinosis, by definition, has CKD stage 1, even if your kidney function, because you are at risk for kidney disease. A mild decrease in GFR, that's 60 to 90% kidney function, stage 2. Moderate decrease, 30 to 60% kidney function, stage 3. Severe, 15 to 29%, stage 4. Kidney failure, less than 15. And so you need to be making plans for dialysis or kidney transplant when you hit a GFR of about 10%. So what often happens is you hear what your serum creatinine is in the doctor's office. And in that last slide about the GFR and what doctors use to determine your kidney function, there was no serum creatinine on that slide. The serum creatinine is an interpretation, and it helps you figure out what your GFR is. But you need to understand that it's not the same thing. So let's start with my labs, okay? So this is a screenshot from my iPhone, and I can use this because it's my own, so I'm not running afoul of the HIPAA laws. So I click on my iPhone, I go to the test results. It brings up a metabolic panel, basic metabolic panel. I click on that, I get some numbers. And if I scroll down, I find a creatinine, 1.3. What does that mean? Well, at Stanford, your little app says that gives me a GFR of about 65%. Okay. But look down below. If I was African American, my GFR would be better. Why is that? Do blacks have better kidneys? No. What happens is, if I was standing right next to a black person, same age as me, same sex as me, he would have more muscle than I have, on average. Caucasians, Asians have less muscle than blacks who are the same weight, same height, same age. Muscle makes creatinine. So you'd expect a black person to have a higher creatinine even though their kidneys are just as good. So this is trying to make a guess about the connection of muscle and creatinine. This little girl, her creatinine is 0.5. All right, she's skinny. Guess the creatinine. So when Arnie was in his prime, taking all sorts of anabolic steroids, muscle building, he had a creatinine probably about 2.3. Now, if I had a creatinine of 2.3, I'd be talking to a nephrologist and calling my sister, do you have an extra kidney? When he moved on to movie star fame, he wasn't working out quite so much, maybe 1.9. And then when he was recently our governor, isn't that awful? His creatinine would be 1.3. So you need to understand the muscle mass and nutrition so you can interpret the GFR. Here's a patient of mine. He was a 16-year-old, used to be very adherent with all his medications. And when he turned 13, Mom started finding pills in his pockets. And when he went to summer kidney camp, Mom cleaned the room and found hundreds of pills under the bed. You look at the serum creatinine, and so I've got a graphic here, and there's some I can't even read that, 2808 down to like 2015. And if you look at the serum creatinine, you see that it was kind of slow, started going up, and then at the end it went up really, really quickly. So the family are saying the kidney failure is advancing, something's happening, he's not taking his medications. But if you actually plotted the GFR, which is more accurate, it's actually a straight line, and he was losing his kidney function. So that had been going on at the same rate for years. So putting bamboo shoots under his fingernails, accusing him of being a bad kid this year, would have been wrong. This person was losing their kidney function gradually over the years. The problem is the relationship of your serum creatinine and your GFR isn't a straight line. So here we've got, it would be lovely if the kidney function here and the creatinine here were a straight line. It isn't. This is the relationship. So you can't look at a serum creatinine and guess the GFR by looking at a table or something like that. It's complicated. We also find that as your kidney failure progresses, the serum creatinine goes up faster and faster. And I'm showing this graphic showing the change of a serum creatinine of 1 to 2. See that big red line? So if we have this person whose kidney function has been plotted there, that's how much distance it takes to go from a 1 to a 2. From a 2 to a 3, it's shorter. From a 3 to a 4, it's shorter. And even shorter still. And this is what we hear from the patients all the time. Oh yeah, his kidney function was going down. His creatinine took years to go from 1 to 2. And only a year to go from 2 to 3, and just 6 months to go to 4. It's speeding up. What are we doing wrong? Nothing. Because people lose their renal function at a relatively constant rate, if you plot the GFR, you find most of these people are a straight line. And it helps you predict what your child or you are going to need and when over time. So this is an example of someone, we've got 10 years of GFR showing a gradual trend down. And these are other patients, all showing the similar thing. The dots show that when you are on the tail end of your kidney function, you get into a straight line. Now here, this person was doing well for a while, 8 years, and a straight line down. But that was 4 years, so you could predict the need for dialysis and finding a kidney transplant. And here's another example. This one is interesting. So even though you might have a low GFR, like this person had a GFR of about 40, their rate of loss was very gradual. So that person had kidney function that was life-sustaining for years, even though they had a low GFR, because their slope was very shallow. So you need to know what your GFR is and be looking at it over time to sort of make a plan. The rate of loss of GFR is usually constant in most people, so we can often predict when that person might need dialysis or transplant. So looking at your creatinine and GFR must be interpreted. Like, say the doctor says, your weight is up. That could be good. If your weight goes up because you had been malnourished and now you're at a healthier weight, or you were working out and you put on 10 pounds of muscle. But if the doctor says your weight is up, that could also be bad. If you have fluid retention, if you have fat retention, or if you're constipated. So the same thing, the GFR and the serum creatinine must be interpreted based on what's happening to you or your patient. So this is a patient of mine, and this is his GFR graph. And so over about 5 years, his GFR went down, down, down. And at this point, his GFR was about 12 or 14. His father wanted to give him a kidney transplant. He said, Doc, I feel fine. I don't want my dad to have an operation. I'm not going on dialysis. I'm good. And I kept saying, look, the numbers show that you're going to be in trouble. This is the time. And you can't hold down a teenager. You can't force him to get dialysis. And so we just watched him. But look at that. His GFR stayed exactly the same for a year, according to the graph. What happened? Did he get a homeopathic therapy? Did he find a miraculous cure? Did he sell his soul to the devil? No. What happened was he started feeling crummy. He lost his appetite. He lost 10 kilograms over that year. He went from being a varsity athlete to being unable to exercise or even go for walks with his mom. And his grades fell from A's to D's. So all the things that you see with chronic kidney disease was happening to him. But his serum creatinine and GFR, calculated GFR, didn't change because those numbers are inadequate. So we looked at the patient. And then he said, okay, I give up. I've screwed up my senior year in college. My grades are poor. I feel like crap. Okay, I want my dad to transplant me tomorrow. I said, I can't transplant you now. You're too sick. The risk of running into trouble is too much. So we're going to put you on dialysis. And once you get healthier, then we'll transplant you. So we put him on dialysis. 3 months later, he comes in. He says, Dr. Grimm, you are the worst doctor. I hate you. Why? I feel so much better now. You should have made me go on dialysis last year. I would have had better grades. I could have gotten into better college. It's your fault. You can't force a teenager. But the point is you have to look at the patient in addition to the serum creatinine and the GFR. You've got to figure out their weight, nutrition, muscle mass, their general health, their activity, their school performance, and you put that into a package and decide when they need us to advance. Now, in calculating the GFR, the numbers we use are the serum creatinine and the height. There are more accurate estimates that include the height, the serum creatinine, the cystatin C, which some hospitals measure, and then the BUN, and you can put that together into, and the sex and the length again, you can put that together into an estimated GFR. But what you can do as a parent, whether your patient has serum creatinines and cystatin Cs or just or serum creatinines, is you can go to websites to calculate your child or your serum creatinine and their GFR. So you can just plug in a Google search for pediatric GFR calculator. And you'll come up with pages like this where you can plug in the numbers you know, their height, their age, their sex, their BUN, creatinine, whatever. And it gives you the GFR. There's another example. For adults, the most accurate calculator is called the CKiD Epi. So again, you go to a website, just do a Google search, you plug in CKiD Epi or adult GFR calculator, and you can calculate your own kidney function based on those numbers. And you can start predicting what is the time course over which you're losing your kidney function. It's really important because people go to the doctor and they're wondering, is this the day the doctor's going to tell me I need a kidney transplant? Is this the day I'm going to be told I got to go on dialysis? Knowing it and being able to predict improves your understanding, and it empowers you and it reduces the stress. If you can say, okay, we've got a game plan, it's going to be 3 years or 2 years or 10 years. The other thing is you can help your kidneys last longer. Now, there are certain things you can't help, like fate. When were you diagnosed with cystinosis? If you were diagnosed at a young age because your older brother has cystinosis, and so you were diagnosed at a month of age and put on cysteamine therapy, your kidneys are going to last a lot longer, but you have no control over that. Obesity, you have control over. Activity, you have control over. Cholesterol, you can have control over. Exposure to cigarette smoke, all these things are bad for your kidneys, you have control over. Controlling high blood pressure. If this is your doctor, when they check your blood pressure, you're in serious trouble. Diet. There's more and more data on the importance of diet. And so in America, there's something called the DASH diet, which is a dietary approach to sensible management of hypertension. There's the Mediterranean diet. There's the new Canadian Food Guide recommendations. And the important thing is half the plate should be red or green or yellow. Half the plate should be veggies. And no teenagers fries are not a vegetable. Pardon? Salsa? Oh, salt is red. That's good stuff. A little bit of salt there, but that's okay for you guys. Okay, starches, only a quarter of the plate. And proteins, beans, meat, chicken, fish, eggs, another quarter. So half the plate should be colored. There's a study that looked at kidney transplant patients. So these are people who had a kidney transplant, were living with a kidney transplant, and they scored people based on the DASH diet numbers. And on this graphic, having a low number is basically you're a carnivore. You know, your idea of breakfast is bacon, just bacon. At the other end, the high number is as if you're totally vegetarian, okay? So this was the typical reported diet of patients living with a kidney transplant in the USA, and there's like 800 patients. When they broke it down, if you looked at the average, okay, the average chance that your kidney was going to last or the average chance that you were going to live, you were twice as likely to lose your kidney transplant. You were twice as likely to die during the observation period if you were carnivorous. Half as likely to lose your kidney transplant. You were half as likely to die if you were mostly vegetarian. Let that sink in. Your choices of your diet, and for your 14-year-old, your 12-year-old, their dietary choices can slow down loss of kidney function. So I'm not saying that you should become a vegetarian. I love a steak. My favorite food is poutine, which is cheese curds and gravy on French fries. But in moderation, increasing the dose of protein from plants will help your kidneys last longer. This is the acid load data. Oops, I can't go. Can I go back? Oh, there we go. This is acid load. And what they did was they look at your dietary acid load, and the people that have the highest acid load have the quicker loss of kidney function. Now, what foods make acid? It's not lemons. Lemons actually are an alkaline load. The things that make acid are things like processed cheeses, meat. The things that are alkaline, which neutralize or antagonize acid, are the fruits and vegetables. So the more fruits and vegetables in the diet, that reduces the acid load, which makes it easier for your kidneys to function, and that helps keep your kidneys lasting longer. So that's something that you can make choices of. So that's why I just love this. There's your beautiful kidneys covered with vegetables and fruits. And that making those decisions will help. Polyuria. In the patients with cystinosis, this is a major problem, you know. And she's kind of cute doing the pee-pee dance. But if you give it time, that leads to that giant bladder with back pressure on the kidney and loss of kidney function. You don't want this to happen. So you never want to see your child doing the pee-pee dance. You want to encourage that they have good bladder habits, voiding frequently to keep the back pressure on your kidney down, to keep the risk of urinary tract infections down. So we've talked about polyuria. More fruits and vegetables improves the potassium in your diet. Treating anemia, there's more data that shows earlier treatment of anemia might keep your kidneys functioning longer, so making sure you're not too anemic. Proteinuria. So when you measure the urine protein, and there's a lot of protein, it's like a beautiful old car being pushed too hard with a lot of smoke coming out of the tailpipe. To explain proteinuria, you have to sort of do a little bit of a kidney anatomy study. So there's the kidneys. They're really, really well protected, way in the back of your body, shielded by your spine and by big, heavy muscles on either side. They are one of the most protected organs right beside the brain. They're really important. At this point, I was giving a talk about 2 years ago, and some teenage girl stuck her hand up and said, "Does that mean the testicles are the least important organ in the body?" I didn't answer that. So if you go zoom in on the kidney has all these little filtering units. And you zoom in on the filter, and the glomerulus is the primary filter. And so blood flows through the glomerulus, and urine leaks out, just like a coffee filter. But when the kidneys are losing their function, when you have less glomeruli, they work too hard. The pressure inside the glomerulus goes up, and they start leaking protein. So your doctor may have talked to you about ACE inhibitor therapy. So as your proteinuria gets worse, as your GFR starts going down, if you start a patient on lisinopril, enalapril, captopril, or the ARBs like losartan, valsartan, telmisartan, olmesartan, it tells the glomerulus, relax, take a coffee break, slow down. And when the glomerulus slows down filtering, it lives longer. So what we aim for is about a 10 or 20% fall in the GFR in the first 3 months of treatment. That predicts better long-term function. So when we put our patients on ACE inhibitors, this is what's happening. So here we've got a theoretical loss of kidney function over about over year age, right? If we start an ACE inhibitor there, your GFR goes down kind of quickly for a few months, but then it stabilizes. The glomeruli don't work so hard, and it lasts much longer. So young kids with cystinosis, we can't do this because they're hypotensive already. They're polyuric, and ACE inhibitors are very difficult. But once they start having significant proteinuria, that's more than just the tubular proteinuria, you can delay the progression of kidney failure. And you can also do this with kidney transplants. So here's a person who's got an expected GFR loss over 7 years. If you initiate therapy with ACE inhibitors, you also get them to lose weight, you get them to eat more of a vegetarian diet, you can extend the life of their kidneys by 2 or 3 years, which is a lot when you consider the cost of dialysis is over $100,000 a year. And the cost of a transplant in your quality of life is substantial. If you can keep your own kidneys lasting a bit longer, that's going to be good. The sooner you initiate therapy, the sooner they are, you get them healthy, you get them active, you get them on a more vegetarian diet and maybe ACE inhibitors, you extend the life of their kidney function even longer. So those are things you can do. I'll skip this slide for now. So the bottom line is that measuring your kidney function and understanding it based on the GFR empowers you, reduces your stress and your anxiety, and helps you plan for the future. And those things such as more vegetarian food, reducing polyuria, reducing the pee-pee dance, ensuring people are active physically, reducing exposure to smoking, and maybe ACE inhibitors later on will allow that kidney to last much longer before you have to get into a conversation like this. Thank you very much. Mm-hmm.
Thank you, Dr. Grimm. That was a great summary of kidney renal replacement anticipation. Our next speaker will go over some of the adult complications of cystinosis, and we have a special introduction for her. This is Dr. Langman.
So I just want to introduce Rachel Kasimer. We were asked to think about, and happily because we've heard already that there are more and more adults living with cystinosis, we were asked to put together what's known about the complications of cystinosis specific to the adults. And as part of Northwestern's medical school program, the students have to do what's called a senior thesis, and I was lucky enough to meet Rachel with a course and work together, and she's going to tell us about a very formal process of how that was achieved. And I want you to be especially nice to her because whatever she did is really her brilliance. And so, Rachel, come up and tell us about the adult complications of cystinosis.
Thank you so much for inviting me here today. This talk is going to cover what data we currently have about the late onset complications of cystinosis. With improvements in dialysis and kidney transplantation, as well as the introduction of cysteamine, more and more children with cystinosis are living into adulthood. While the kidneys are one of the first organs affected, cystinosis in adults is a multi-system disease. Adults with cystinosis see adult nephrologists and primary care doctors, rather than pediatric nephrologists and pediatricians, meaning that their doctors may not be as familiar with the disease. As such, we thought that a review paper about this evolving patient population was called for to synthesize the broad range of information available for those who care for children with cystinosis to know about the complications that their patients may face as they become teenagers and adults, as well as for those practitioners who treat adults. In this talk, we'll cover both the prevalence of the more common complications as well as some of the less common ones, and discuss some of the complications that are less well characterized and may have only been mentioned in case reports. In order to discern what data was available about this topic, we queried multiple different databases, including PubMed, Scopus, Embase, Web of Science, and the Central Database of Clinical Trials, searching with the terms cystinosis and adult. All of the relevant papers were included, and the key points from each were sorted according to the corresponding organ system. The goal of this study was to look at complications of cystinosis that arise in adults. Oh, I'm sorry. Two of my papers stuck together. There we go. We also wanted to be able to quantify the strength of evidence that each paper contributed. In order to determine the level of evidence of each of the studies included, we used the Oxford classification scale for systematic reviews. This grades studies primarily based on the study design. The strongest studies, which are typically the meta-analyses of randomized controlled trials, are given a level of evidence of 1, while those that use logical conclusions rather than actual data are given a 5. The studies that we found were primarily 2s through 4s, and for some organ systems, there were only case reports and case series available. The goal of this study was to look at complications of cystinosis that arise in adults, so studies that included only children were excluded. We also wanted to look at primary data, so review articles were excluded. Studies trying to elucidate the pathophysiology of cystinosis, such as genetic, biomarker, and biopsy studies, were also excluded. Our goal was to figure out what complications adults with cystinosis face, rather than how those complications occur. Now we'll go through several of the organ systems involved, starting with the cardiovascular system. So the way that these slides are organized, there are multiple different studies that we found. The y-axis shows how many patients were included in each study to give you a sense of how large or small these trials are. Some of the bars that you'll see have percentages. Some studies looked at a specific complication, and the prevalence of that complication is listed there. The ones that don't have those percentages, it's because they looked at several different complications. So a single number wouldn't really represent it. So the most common complication of cystinosis affecting the cardiovascular system is vascular calcifications, or atherosclerosis, affecting about 1/3 of adult patients. As vascular calcifications are also caused by chronic kidney disease, it's unclear whether this is a direct consequence of cystinosis or if it occurs due to the resulting chronic kidney disease. The only study that compared those with cystinosis to a control group with kidney disease not from cystinosis looked at non-invasive measurements of atherosclerosis, which showed no difference, suggesting that this is an indirect complication. Abnormal EKG findings are also present in about 42% of patients, but it's unclear what the clinical significance of these abnormalities is. Case reports have described patients with presumed cardiac complications of cystinosis. One case report describes a patient with heart failure found to have cystine deposition in cardiac muscle. While this could suggest that cystine deposition in cardiac muscle can lead to heart failure, these could have also been unrelated. Perhaps many patients with cystinosis have cystine deposition in the heart with no clinical consequence. Another had aortic aneurysm, which also could have been due to several alternative mechanisms. Two other case reports describe a patient with ventricular non-compaction, which is a congenital anomaly not known to be related to cystinosis, and pregnancy-associated cardiomyopathy, which could have been due to stopping cysteamine during pregnancy or from the pregnancy itself. Overall, while the cardiovascular system is affected in cystinosis, it's unknown at this time whether or not cystinosis directly affects the cardiovascular system or whether those with cystinosis are affected in the same way that any other person with chronic kidney disease would be. The case reports describing more specific complications could be describing complications of cystinosis, or simply two disease states that happen to occur concurrently. Almost all of the studies regarding the hematologic complications have been case reports. One observational cohort study showed a prevalence of splenomegaly, meaning enlargement of the spleen, requiring spleen removal, to be 21%, but noted that no spleens were removed after 1997 in that cohort. Enlargement of the spleen is thought to be due to cystine deposition into the spleen, and the dramatic reduction in this complication over time suggests that cysteamine may prevent it. A few case reports describe anemia and pancytopenia, the reduction of red blood cell counts, platelets, and immune cells. These patients had bone marrow biopsies, which showed deposition of cystine in the bone marrow, preventing the production of red blood cells, platelets, and immune cells. This complication is particularly interesting, as patients with chronic kidney disease are commonly anemic due to insufficient production of erythropoietin, which is produced by the kidneys to stimulate bone marrow production of blood cells. This form of anemia, however, would not improve with the administration of erythropoietin, as the problem is with bone marrow production, not with bone marrow stimulation. Oftentimes, the anemia and pancytopenia in cystinosis is mild, but occasionally, when compounded with another trigger for bone marrow suppression, it can be severe. One patient developed HELP syndrome, a severe, uncommon complication of pregnancy. After delivery, she was persistently pancytopenic, which triggered the bone marrow biopsy showing cystine deposition. It's possible that without that trigger, she simply would have had mild cytopenias that never would have triggered a workup. It's also worth noting that the chronic immunosuppressive medications that many patients with cystinosis take for their kidney transplants carry their own hematologic complications. These can cause an imbalance of immune cell production, and in one case report, caused one patient to develop a form of leukemia or lymphoma that's associated with immunosuppressive medications. GI complications are nearly universal. More commonly, patients report periods of nausea and vomiting, as well as decreased appetite. In one survey, 50% of patients underwent a GI evaluation. Almost half of those evaluated were found to have GERD, or acid reflux, and problems with esophageal motility were found as well. These GI complications can be so severe that some require PEG tubes to get enough nutrition, up to 78% in one cohort. Swallowing dysfunction is also a common complication of cystinosis, but this is primarily thought to be a muscular issue, so it will be discussed later. Liver enlargement and portal hypertension, a backup of blood flow from the liver, can occur, likely due to cystine deposition in cells in the liver. While it can change the shape of the liver, we did not find any case reports about it causing cirrhosis, which is chronic scarring leading to liver failure. Other GI manifestations are from medications themselves, including halitosis from cysteamine. An interesting phenomenon noted in one paper was the use of chlorophylline, a copper-containing substance, in the US to mask the breath of those taking cysteamine. There was a cohort of patients who experienced side effects of cysteamine, such as skin abnormalities and muscular pain. All of these patients were also found to be copper deficient, and all lived in Europe where chlorophylline is not used. This puts forth the hypothesis that the side effects of cysteamine are mediated through copper deficiency, which can be prevented with chlorophylline administration. In addition, one case report describes a patient with overgrowth of the gums who was also on cyclosporin. As this is a side effect of cyclosporin, they initially thought that the gingival overgrowth was from the medication. However, when they did a biopsy of the gums, they found cystine deposition. It's unclear whether or not the cystine contributed to the overgrowth, but it certainly complicates figuring out the cause. Neurologic involvement is uncommon, but can be debilitating when present. The most common complication is cystinosis-associated myopathy, which is primarily muscular in origin rather than neurologic, and explains the higher percentages that you see on this slide. The most prevalent, primarily neurologic complication is increased intracranial pressure, which is present at a prevalence of 5%. While those with chronic kidney disease are at a higher risk for elevated intracranial pressure, the rate of 5% is higher than one would anticipate, suggesting that there's something specific about cystinosis that causes it. The cause itself is unknown, but some speculate that it has to do with cystine deposition, causing decreased absorption of cerebrospinal fluid, causing it to build up. Cystinosis has also been known to cause two major syndromes affecting cognitive functioning. One syndrome, sometimes referred to as the encephalopathic form, is characterized by mental deterioration in association with gait abnormalities and appears as a generalized cerebral atrophy on MRI. The other syndrome presents more similarly to a stroke, causing symptoms such as hemiplegia, the inability to move one side of the body, or coma. This form is associated with more discrete calcifications seen on MRI. There have been autopsy reports showing cystine deposition in the brain, but again, it's unclear if that deposition contributed to the clinical picture. Just as the chronic immunosuppression in cystinosis can lead to hematologic complications, so too can it cause neurologic complications. In one case report, a patient developed cryptococcal meningitis, a fungal brain infection that exclusively impacts those who are immunosuppressed. There has also been a case report of a neurologic entity called posterior reversible encephalopathy syndrome, which can include seizures and mental status changes, which was attributed to cysteamine. This was only present in one case report, and the causal relationship was not completely clear. Endocrine complications are quite common. Hypothyroidism begins to manifest at around age 12, and overall affects anywhere between 30 to 89% of patients. One study showed a difference in prevalence of hypothyroidism depending on whether or not someone was taking cysteamine, suggesting that cysteamine may play a role in preventing the onset of hypothyroidism. Diabetes is also a common complication and appears to occur through multiple mechanisms. Those with cystinosis have typically undergone kidney transplantation and have therefore been exposed to high levels of steroids, which can cause diabetes. However, their rates of diabetes are higher than those of other kidney transplanted patients, suggesting the prevalence of an alternative mechanism. This secondary mechanism is likely decreased insulin production, as shown by one study that showed that insulin and C-peptide, a compound released with insulin, are decreased following the intake of sugar in those with cystinosis. Short stature is nearly universal, along with delayed bone age. The use of recombinant human growth hormone has been used to increase height with good success. Finally, the reproductive system can be impacted, specifically in males. It appears that this is due to cystine deposition in the testes, decreasing the production of testosterone, as the hormones that stimulate the testes to produce testosterone are high, while actual testosterone levels are normal, but decrease when compared to those without cystinosis. Both men and women have delay of puberty, but while men have decreased fertility, there have been several case reports of women with cystinosis conceiving and delivering babies. One of the more well-known musculoskeletal complications of cystinosis is myopathy, or muscle disease. It typically begins in the small muscles of the hands. From there, it can spread to include the larger muscles of the arms, as well as affect the legs. The prevalence varies depending on the study, but it appears to affect up to 50% of those with cystinosis. However, one study that did formal strength testing of those with and without reported symptoms showed that even those without symptoms still had weakness on formal examination. The myopathy is thought to be caused by the deposition of cystine into muscles, as one biopsy of a patient with severe myopathy had cystine concentrations that were 1,000 times normal. It also appears that cysteamine prevents myopathy and may stabilize or slightly improve it if introduced after the myopathy begins. The myopathy does not just influence the muscles of the arms and the legs. It also affects the muscles that are involved in breathing and swallowing. The difficulty breathing can be found when performing pulmonary function testing, but is also characterized by normal chest X-ray and chest CT results. The breathing difficulty means that some of those with cystinosis use equipment to help them breathe at night, called non-invasive ventilation. The swallowing dysfunction affects up to 75% of patients and can lead to gagging, pain with swallowing, voice changes, and aspiration pneumonia. On the more skeletal side of the musculo-skeletal system, those with cystinosis are noted to be at high risk for the development of fractures, possibly from cystinosis directly or indirectly from chronic electrolyte abnormalities due to kidney disease. Cystine deposition can occur in the skeleton itself, causing asymptomatic lesions that can be found during routine imaging studies. While around half of those with cystinosis in Germany have reported orthopedic problems, they're still able to remain active, and a quarter of those with cystinosis overall report being active in sports. A recent report details reduced bone mineral density, but since this is common in patients with chronic kidney disease, the specificity for cystinosis is uncertain. The eyes are affected early in cystinosis. Usually all patients are affected by age 12. The more common manifestations are decreased visual acuity and photophobia. The decreased visual acuity can be severe enough that 11 to 15% of those with cystinosis are legally blind. However, there are other complications as well, including decreased peripheral vision, a foreign body sensation in the eye, and decreased color vision. More serious complications, such as macular edema and cataracts, can also occur. Oral cysteamine does not reach the eye, so cysteamine eye drops are used. These used to require refrigeration and to be dosed hourly to be effective, but this is no longer the case. Unlike oral cysteamine, which can prevent complications but rarely reverses them, topical cysteamine eye drops can improve visual acuity and photophobia after it occurs. In terms of data quality, this set of complications is perhaps the best characterized, with randomized controlled trials describing the effectiveness of the interventions and high-quality cohort studies describing in detail the anatomic and chemical changes that contribute to the eye symptoms. Thank you.
Thank you to Rachel and Dr. Langman. That was a really, really complete and excellent review of adult complications. So we thank you very much for being here. So that's the end of our session for this morning. I have a few housekeeping details to take care of. I've been asked to remind those of you, as soon as I'm done with this part, to please go retrieve your children from childcare as promptly as you can. Also, there is a item at the Lost and Found desk, or the registration desk, a Simply Southern bag with Cysteine drops in it. We don't want to lose that. Also, I just wanted to go over, so we'll have 3 panel sessions this afternoon. They'll be dividing this room into 3 different sections: Grand Ballroom A, B, and C, and D. And you can see when you take a look at your agenda, there are sessions divided by age, essentially, and you can choose whichever sessions you would like to attend. There are just a couple of notes on them. A couple of the sessions are closed to adults or adults and their partners only, so please check closely into that. There's a special session for parents of adults with cystinosis. I think you've all been contacted in advance, but that is upstairs in Discovery C, so that won't be in this area. And then finally, I was asked to remind you that there is a session in panel session 2 for the teen age group on social relationships and gaining independence. That session is for both teens and their parents, and I've been told that siblings that are of approximately the same age group are welcome to join that session as well. So please enjoy lunch now, and we will see everyone back in here at 1. Thank you.